Hello, my name is Joy Okafo, and today I will be presenting medium-term outcome of low-profile visible intraluminal support or LVIS stent-assisted cerebral aneurysm treatment, a single-center experience. So I'm just going to start by giving a brief background on what the LVIS stent is and how it was used in the study to test for efficacy. The LVIS stent is a self-expanding low-porosity microstent for stent-assisted coil embolization of unruptured intracranial aneurysms. As you can see on this slide, these are examples of the LVIS stent, and these are examples of real aneurysms treated and analyzed in this study in various blood vessels in the body. Essentially, the LVIS stent is a small, flexible device used to divert blood flow in the major arteries mentioned in this study away from the aneurysm itself, in order to prevent the event of the aneurysm rupturing. Now, this was a qualitative and retrospective descriptive study, meaning that the efficacy of the LVIS stent in these specific patient cases was analyzed after the procedure, and all follow-up visits related to the stent placement were already complete. The study began with the compilation of all digital records of patients who had been treated with the LVIS stent in this particular clinic. All personal information, such as names, MRNs, etc., have been redacted from the abstract and presentation for privacy purposes. Once these medical records were gathered, a data table was made featuring the blood vessel the patient had the stent placed in, how many of the stent were used in the procedure, and whether there were any necessary corrective measures or complications after the aneurysm treatment procedure was done initially. There were many other factors and variables featured on the analyzed spreadsheet, such as whether or not the patient was a smoker or suffered from hypertension, but these details did not significantly impact the resulting data. This descriptive study involved the retrospective analysis of 70 patient experiences with the LVIS stent. The male to female ratio was 3:5. The median age was 58.5 years. It was found that 19 of the patients had the LVIS stent placed in their supraclinoid internal carotid artery, 17 had it placed in their basilar artery, 6 had it placed in their posterior communicating artery, 6 had it placed in their vertebral artery, 4 had it placed in their anterior cerebral artery, 2 had it placed in their posterior inferior cerebellar artery, 2 had it placed in their superior hypophyseal artery, 1 had it placed in their posterior cerebral artery, 1 had it placed in their superior cerebellar artery, and 1 had it placed in their anterior inferior cerebellar artery. Now, this was a wide variety of major arteries, which gave us the ability to make more generalizing claims and inclusive results of how effective the LVIS stent really was. A study like this is quite relevant and important considering how new the LVIS stent is, having just received FDA approval and hitting the market in 2018. After analyzing the treatment and retreatment results of all 70 of these patients, the results were quite encouraging, indicating an overall effectiveness of the LVIS stent. At a median angiographic follow-up or X-ray scan of 16 months, it was found that 65.4% of the patients achieved a Raymond-Roy class of 1 occlusion, which means complete obliteration of the aneurysm. 34.6% of patients had only minimal residual aneurysm neck and dome, and only 10% of patients required retreatment. At medium-term follow-up, only 2.86% of patients suffered persistent neurological deficits, and the overall mortality rate related to the LVIS placement was a surprisingly low 2.8%. All these data show that the LVIS stent is a safe option as a coil adjunct for endovascular embolization, with increased efficacy as evidenced by the encouraging occlusion rates, retreatment rates, and minimal complications. As we can see, the LVIS stent is safe because of the low mortality rate, it is successful because of the acceptable occlusion rates, it is effective because of the low complication rates, it's viable because it operates effectively, it's versatile because it can be used for several types and sizes of blood vessels in several different locations, and it's undervalued because physicians should consider this adjunct for coil embolization more often. I would like to thank all the doctors related to this study for helping me and taking me along this beautiful neurointerventional journey. And I would also like to thank all of you for listening.